Lord and Savior Jesus Christ. Welcome to our 23rd Mnemonic in Internal Medicine. In this one, we are keeping up with the Jones. So once there was a guy who went to his doctor, and the doctor said, "Oh, so you say a mosquito bit you, and now you have chills, a high fever, and you're sweating profusely. That's not funny. That's malarious." And what is a baby pepper's favorite temperature? Oh, just a little chilly. So today, guys, we're talking about acute rheumatic fever and rheumatic heart disease. So the pathophysiology behind this is the usual culprit group A, beta hemolytic strep infection, which causes non-suppurative inflammation with cardiac, joints, and CNS manifestations 2 to 4 weeks later. Both post-streptococcus pneumonitis and scarlet fever may occur separately as complications of group A strep infection. So the maxim there is that strep infection, it licks the joints, but it bites the heart. So it causes valvular disease. So to remember the Jones criteria, remember we diagnose acute rheumatic fever if we have 2 major criteria, or if you have 1 major and 2 minor plus evidence of recent strep infection. We'll talk about that. Major criteria is Jones, right? So J speaks to joints. Joints, remember we have a flitting migratory polyarthritis. O is obvious, which speaks to carditis. Not just carditis, but pancarditis. So it can affect any layer of the heart, be it endocarditis in the way of a valvulitis, or myocarditis, or pericarditis. N speaks to subcutaneous nodules, mainly on the extensors. E is for erythema marginatum, and S for Sydenham scoria. So a handy way of remembering the major criteria is just by remembering Jones. Minor criteria, so the mnemonic there is cafe pal. C speaks to a raised C-reactive protein. A is for arthralgia, not necessarily arthritis, but arthralgia, which is just painful joints. F speaks to fever, and E is ESR is up. You also have a PR interval prolongation on the ECG. A stands for anamnesis, which is a fancy way of saying you got a history of previous joint involvement, and L speaks to leukocytosis. All right, so you diagnose, we said, based on the Jones criteria. You can make a diagnosis of acute rheumatic fever if indeed you have 2 major criteria or 1 major plus 2 minor criteria, plus evidence of antecedent strep infection in the way of a positive throat culture, a rapid antigen detection test, or elevated anti-streptococcal antibody test, or anti-streptomycin O titer, or anti-DNase B, or anti-hyaluronidase, together with a positive throat culture and findings on echo as well. So how do you treat this thing, guys? Well, patients with rheumatic disease are at high risk of recurrent rheumatic fever, and recurrent disease causes additional valve damage, and thus these patients should receive secondary prophylaxis for rheumatic fever in the way of benzathine penicillin G, 1.2 million units IM 4 weekly, or you can go penicillin V, which is the oral form, 250 milligrams BD per hour, or azithromycin, 250 milligrams daily if allergic to penicillin. So for patients with valvular involvement, therapy should continue for at least 10 years or until the age of 40, whichever is longer. With a history of carditis in the absence of persistent valvular disease, we treat for 10 years or until the patient's age 21, whichever is longer. So there you have it, guys. Acute rheumatic fever, diagnostic criteria, Jones criteria. The mnemonic is Jones Cafe Pal. God bless you.